Ladies and gentlemen, yes, we were about to forget that we still have some patients who have a normal response and who have a good prognosis. So let's talk about this. These are my conflicts of interest, and let's warm up. Ladies and gentlemen, when prescribing a GnRH antagonist protocol in a, well, with a pre-treatment of estradiol valerate or micronized estradiol, what will that do with the cycle? Will it increase the number of oocytes in low responders, in normal responders, or only in low responders, only in normal responders, or will not increase the number of oocytes at the point of oocyte retrieval? What will the pre-treatment of estradiol do in an antagonist protocol? Or just for scheduling purposes and programming the cycle? Okay, everybody has voted. Then maybe we can go to the next slide. Majority of the people says that it will not increase the number of oocytes at oocyte retrieval, but still 50% thinks that it will increase. Let's see what it gives in the answer. Do you love oocytes? Do you like oocytes? The higher, yes, the higher the number of oocytes, the higher the number of blastocysts, or the higher the number of euploid blastocysts, or the higher the cumulative live birth rates, or all of the above. Please put your vote. Belgium, 12 points. Tunisia, 10 points. All right. Okay, it was an easy one. Okay, thank you very much. Now we can proceed, because, ladies and gentlemen, we have a problem. As I told you in the beginning, there is good news and there's bad news. Well, there is also a lot of bad news, because not only that 30% of the couples will require IVF when suffering from infertility, but also we are not performing very well, because only 30% of top quality embryos will eventually lead to a healthy son or a healthy daughter. So we always need to think in terms of how to improve the benefits, the outcomes for our patients. And one of the crucial aspects is, of course, the ovarian stimulation. This is what we are talking about in the morning: ovarian stimulation, and trying to avoid enemy number one, excessive response and OHSS, and also cancellation of the cycles because of a poor response, or call it low response. Those patients are not poor responders, but low responders. So we need to talk about the normal responder patients. And the question is, of course, who are they? Is there a clear definition about patients with normal response, the so-called perfect IVF patients? It's not a low responder, and we know now the definition of the low responder, and it is not a high responder. So we are talking about this kinds of patients, and it is very well established that these patients benefit, according to the ESHRE guidelines, by a classical GnRH antagonist protocol with a dose of 150 and 225 units of gonadotropins. The addition of Other agents such as clomiphene citrate, letrozole, is probably not immediately recommended in this category of patients. So yes, besides the good old long agonist protocol, I do not think that I need to convince you about the advantages of the antagonist protocol, which is one, the lower rate of OHSS. This is very well established by this meta-analysis of Niels Lambalk. And also at the level of the live birth rates, there seems to be no difference. So what is withholding us from prescribing a GnRH antagonist protocol? Well, we will see, because we have to point here. I need to start again. With you, it will work, of course. That's the pointer. Yeah, but next slide. Okay. Similar live birth rates, but there is one single issue, namely that the synchronization of the follicular cohorts is maybe different in a antagonist protocol as in the agonist protocol. We are overwhelmed by gonadotrophins. We have the choice, and that was the evolution. Of course, today, because it's a bit of an old slide, we should add the folitropin delta compound as well, which has come to the market recently. So the choice is there, and probably in normal responder patients, there is no real evidence of a difference between the two gonadotrophins. But talking about the synchronization again, we do have 1 or 1.5 oocyte less with an antagonist protocol as compared with the long agonist. So talking about that, we could maybe pre-treat our patients with OCPs, with the pill, oral contraceptive pill. It does not offer only a very nice tool of scheduling, of programming, of organizing the unit, which is of extreme importance in many centers, but also in terms of synchronization. But please, I would strongly suggest you not to use the pill, because this is an updated meta-analysis that we know already from the old days by George Griesinger in 2008 and 2010. This was the study by Farquhar, who stated that when prescribing the pill OCPs as a pretreatment for an antagonist protocol, that pregnancy rates will be significantly lower. So maybe we can use this to schedule, to program, and to try to avoid weekends by putting estradiol valerate or micronized estradiol, if you wish. Mostly in France, it's micronized estradiol. And we start in the luteal phase with these tablets. Menstrual period will occur regardless of the administration of E2, and then you start on the day that you wish. So the next question is, of course, will it also synchronize? Well, the answer is no, because indeed we see that the number of oocytes will be exactly the same. Also at the level of the live birth rates, there was no difference. So probably this is the difference between the OCP pills versus E2 only, that you miss the gestagen component, which is maybe causing this deleterious effect at the level of the implantation. E2 pretreatment. Allow me to go back to the low responder patients. What about E2 in the low responder patients? Well, we are spoiled with a very nice randomized trial. More than 550 women were included in the analysis. And there again, also, it was stated that the number of oocytes was exactly the same. So in terms of synchronizing to increase follicular recruitment, to increase the number of oocytes, we cannot be helped with E2 pretreatment. It is just an option to schedule or to plan. What else can we do? Well, let's go to Turkey with Barış Atta, who said, "Well, why make it so complicated and start in the luteal phase? Let's just give a 3-day course of E2." And this is what he did in donor cycles. So he used oocyte donors, gave them 2 stimulations, one without any pre-treatment, and the other one with 3 days of estradiol. So the estradiol scheduled cycles, which had 1 day of stimulation more, the need for 1 day of stimulation more, and you see that a similar number of oocytes was retrieved. Also in India, for example, in India, they work in so-called batches, because there is one embryologist for 8 or 10 centers, so they can only do oocyte retrievals on Tuesdays in that center and on Wednesdays in that center, for example. There it is also of extreme importance to schedule and to plan. And as you can see, at the moment of the menstrual period, you can start with a varying number of estradiol valerate, or in this case, estradiol hemihydrate, before the desired start of ovarian stimulation. And this is what he did in a prospective trial, again with oocyte donors, in which he, Manish Banker, he observed an increased number of oocytes in the E2 pre-treated group. Of course, when I talked to him recently, I said, Manish, how do you manage to have 36 and 32 oocytes in these patients? He said, well, no, everything okay, no problem. So, okay, 36 oocytes versus 32. Anyway, talking about cycle programmation, maybe it is completely outdated, as Sandro Esteves would say, with his AI group, because maybe in a couple of years, based on many parameters, we will be able to predict the ideal day of having the oocyte retrieval. We are, in our unit, we will be starting soon with gathering data based on 16 different parameters, such as age and BMI and body weight and everything you wish, and put it in an algorithm and see then, based on probably 36,000 cycles, what could be the value of AI in programming the cycles and trying to have a more or less synchronized number of oocyte retrievals during every day. Because you can imagine in our lab, where we have 5,500 cycles per year, it is important not to have 6 oocyte retrievals, but also not 24. So we try to have around 18 to 20 oocyte retrievals per day. And we do manage more or less, if I can ask the agreement of my colleagues in the room. How many oocytes do we wish? We are talking about the normal responders, the good prognosis patients. How many oocytes do we want? The more, the better, or let's not exaggerate. And there is no real consensus in the literature, but as was shown before by Carlo, it seems to be that based on this analysis, and you have seen this slide many times, and the Sunkara, based on 400,000 cycles, that there is more or less a plateau reaching at a number of eggs of around 15 to reach a good live birth rate. This paper was criticized a lot, especially by the groups that are pro-mild stimulation, because they said, well, sorry, you're talking about an enormous heterogeneity of patients here. There is no mentioning of the discomfort, of the cost for the patient. There is no complication mentioning either. So there are some flaws in that study, but more and more data came. And also Nikos Polizos said, well, not only the live birth rates are important, but the cumulative live birth rates are even more important. And then we see that the more oocytes we obtain, the better the cumulative live birth rates will be. And this is the latest study from Fanton in the United States, stating exactly the same. The more oocytes we have, the more blastocysts we will obtain, the more euploid blastocysts we will obtain, which also translates into cumulative live birth rates. But I agree that good response is not the same as profound stimulation. So let's be careful, of course, with that. We don't need 35 oocytes in our patients to have 12 blastocysts in our fridge. This paper has been shown already. It was Bob Fischer who said, it is not the number of blastocysts that will impact the euploidy rates. No, it is the age of the female that has a direct impact on euploidy and aneuploidy rates, of course. So there, no relationship. What with regard to the dose? High gonadotrophin doses. I don't want to tell you that we need to hammer our patients with over 300 units of FSH. There is a very nice study from our Turkish colleagues, Berkanoglu, who said when comparing 300 units with 450 units with 600 units, that there was no difference in terms of outcomes. So let's not hammer our patients, but high gonadotrophin doses do not impair euploidy rates for our patients. So no problem at that stage. This is also an interesting study. It was Elena Labarta from Valencia who said, well, if this might hinder the euploidy rate, let's compare a natural cycle with a stimulated cycle and look at the blastocyst, the euploidy of the blastocyst, so PGT. And what was the result? Well, exactly similar euploidy rates were observed in a natural cycle as compared with a stimulated cycle. Let's go a bit further and in our stimulation, and how are we going to trigger our patients? How are we going to trigger with the good old HCG? Of course, because it can also help our luteal phase support. It has this luteotropic effect that lasts for maybe between 5 and 7 days, as compared with the GnRH agonist. GnRH agonist has a very more rapid action, will not only have the LH surge, but also the FSH rise. So actually you could say, well, this rather belongs to nature as compared with ATG. And then we could maybe combine these two agents, talking about normal and also then low responder patients. Why not use the dual trigger? Because there are some retrospective data before we go to the prospective ones, retrospective data showing some conflicting results. There was significant improvements observed in clinical pregnancy rates, live birth rates. Then other papers did not manage to show any improvements at the level of embryo quality. So what is going on with this dual trigger? Well, in this meta-analysis, and now we are talking about 8 randomized studies, it was stated that when using the dual trigger compounds, that you will increase the number of oocytes. You will increase the number of mature oocytes, fertilized oocytes, and usable blastocysts. Of course, not all these studies went to the stage of live birth rate. That remains a question, but maybe this could be beneficial. And we were especially surprised, positively surprised by this study from our colleagues in Israel, who said, well, let's do a randomized trial, straightforward, 150 patients. This was an interim analysis. HCG versus dual trigger. More oocytes, more mature oocytes, more top quality blastocysts, and look at the live birth rates. A spectacular increase of the live birth rates from 22 to 36%. So when this publication came out, we said in our center, no, we need to change our strategy. And from 2020 onwards, we changed our strategy from mono trigger with HCG to dual trigger, HCG plus triptorelin in our hands, not buserelin, but triptorelin 0.2 milligrams. And I had the honor to present our data now after a couple of years at Este, Copenhagen in June or July. So we scrutinized all our normal responder patients, normal and low responder patients from 2017 to 2022, with a change, of course, in 2020 from mono to dual. So we had 7,000 cycles HCG triggered only, and 1,500 cycles with the dual triggering. And what were our results? Well, we observed that the number of oocytes was significantly higher, that the number of mature oocytes was significantly higher, that the number of fertilized oocytes was significantly higher in the dual trigger group. But the embryo utilization rates, which means the number of embryos on the denominator, the number of mature oocytes, was lower in the dual trigger group in the day 3 arm and was more or less equal in the day 5 arm. The pregnancy rate, ladies and gentlemen, was exactly the same. And now we are still in the stage of looking at the data. You know that going to live birth rates is sometimes an issue. Sometimes we need to call patients actively. So we are still looking at the data of our cumulative live birth rates, which is, of course, of extreme importance. But since this outcome was already established of no difference, we stopped using the dual trigger program in the whole population, and we still leave it for a specific kind of patients, let's say patients with low maturation, patients with low embryo quality rates and so on, in trying to enhance it in this specific population. In the whole population, I'm not convinced that this will bring a benefit. So as to conclude, ladies and gentlemen, normal responders, well, yes, it's a nice group to talk about. And let's use the GnRH antagonist protocol. Antagonist protocol, yes, we can schedule, we can improve the synchronization, and we can program them easily by using E2. Cumulative live birth rates will increase with the number of oocytes, as stated before, and the dual trigger finally, well, to be continued, but certainly not for the whole population. Thank you very much indeed.